Recording in progress.
Pathophysiology. Premature pancreatic digestive enzymes within acidic cells, leading to activation of other enzymogens and resulting in pancreatic autodigestion, is assumed to play an important role in pathogenesis of pancreatitis in both humans and cats. Hypotheses for the spontaneous development of pancreatitis include auto-oxidation of ketonic activation of zymogens by thrombin during bacterial toxemia, ischemia, or hypoxia, co-localization of lysosome proteases and zymogen granules, activation of trypsinogen by capsin B, and enterokinase entering the portal circulation after meal in the congestion of the biliary pancreatic reflux, which may cause zymogen activation.
Tôi có bao giờ ăn cơm đâu. Đấy là con này nữa, tối nay học thầy Tuyền. Ai đu đây đu của chú, con ấy đu
association between acute cholangitis or bacterial cholangitis.
Tối chuyển đấy nhá.
High concentration of bile acids or trypsin within pancreatic circulation may contribute to the development of necrosis. The image upper here is the mechanism that protects the pancreas from premature activation of zymogens. And the image lower here is events that lead to acute pancreatitis due to premature activation of trypsinogen, including biliary pancreatic reflux, bacterial toxemia, ischemia, or hypoxia. And here's the local and systemic inflammation ensues in acute pancreatitis, which is independent of trypsin activation, but depends on ongoing stimulation of the NF-alpha B pathway. Here's the pathophysiological mechanisms relevant for chronic pancreatitis that occurred independently of trypsin activation and acute pancreatitis. Clinical signs and physical examination findings associated with both acute and chronic pancreatitis in cats are non-specific. The presenting signs in each case help to characterize the severity of the disease. The common clinical signs including lethargy, anorexia, vomiting, weight loss, diarrhea, dehydration, icterus, or fever. Diagnostic imaging. First one is radiographic. Abdominal radiography is neither sensitive nor specific for the diagnosis of pancreatitis in cats. The left lobe of pancreas occasionally can be identified on the ventrodorsal radiographs in cats with pancreatitis. Radiographic signs of severe pancreatitis include loss of peritoneal detail in the cranial abdomen or a mass effect. Ultrasonography. Ultrasonography remains the most routine diagnostic imaging tool for cats suspected of having pancreatitis. It should be considered part of the minimum database in these patients. The normal pancreas is isoechoic or hypoechoic compared to the surrounding mesentery, and is similar in echogenicity to the liver. So you can compare with the liver. Sonography findings in acute pancreatitis in cats may be equivocal or may include pancreatic enlargement, a hyperechoic surrounding mesentery, and focal abdominal effusion. The duodenum may be distended. Sonographic features of chronic pancreatitis are not well established in cats. Findings may include hyperechoic or mixed echoic pancreas. A dilated common bile duct, enlarged pancreas, and irregular pancreatic margins could be observed. Most of the overlap between these features and those of acute pancreatitis, ultrasonography is a poor diagnostic tool for assessing the chronicity. And here we can see the imaging at left is sagittal plan of abdominal ultrasound imaging of the left pancreatic lobe in a cat with acute pancreatitis. Here we can see the left here. The left lobe of the pancreas is enlarged, diffusely hypoechoic, and surrounded by a halo of hyperechoic mesentery here. And the image at left is sagittal plan of the left pancreatic lobe of a cat with chronic pancreatitis. We can see the pancreas, inflamed pancreas here. The pancreas is mildly enlarged. Parenchyma is diffusely heterogeneous and has a malted echo texture here. The surrounding mesentery is unremarkable. Neuroclinical pathology. A CBC biochemistry profile and urinalysis are part of the minimum database obtained for evaluation of any patient. Although these tests are not specific for the diagnosis of either acute or chronic pancreatitis in cats, they are helpful in eliminating other differential diagnoses and assessing the patient for complications. In cats with acute pancreatitis, indicators of erythrocyte mass may be increased. An inflammatory leukogram, like neutrophilia with left sheet or neutropenia, may be present, usually with acute pancreatitis. In severe cases, evidence for hypocoagulability with DIC may be present, as evidenced by prolonged clotting times, often occurring concurrently with thrombocytopenia. Changes on routine serum or plasma biochemical profile also are variable and unpredictable. Hepatic enzymes concentrations may be increased because of concurrent inflammation of the biliary tree and intrahepatic biliary obstruction, hepatic lipidosis, or some combination of these. Serum creatinine, BUN, and DMA concentrations may be increased as a result of dehydration. In cats with severe acute pancreatitis, azotemia, and low urine specific gravity may result from AKI secondary to hypoxemia, impaired renal microcirculation, or hypovolemia. Azotemia has been linked to the progression of the disease. Hypoglycemia and hyperglycemia can be seen with acute necrotizing and suppurative pancreatitis. And hypoglycemia has been associated with poor outcome. In cats, hyperglyceride is rare and no association of hyperglyceridemia with pancreatitis has been reported. Changes in their electrolyte concentrations are variable, particularly depending on the dehydration status of the patient. But hypokalemia, hypocholemia, hyponatremia, and hypocalcemia are the most common electrolyte abnormal in cats with severe acute pancreatitis. Management of any pancreatic enzymes or damage could be used as a diagnostic marker for acidic cell damage and pancreatitis. However, some enzymes are very small or are scavenged by inhibitors or both, and are rapidly pancreatic cells. So an ideal marker for pancreatitis would be one that is synthesized only by acinar cells and not cleared immediately from the vascular space. So pancreatic lipase fulfills this criteria, but to be useful as a biomarker, the molecule must be measured using an assay specific for pancreatic lipase, which may be a problem. Pancreatic lipase immunoreactivity. In ELISA for the management of FPLI, most of the data suggests that the management of FPLI is highly specific for the management of pancreatic lipase, and it also is sensitive for the diagnosis of pancreatitis. It should be noted that sensitivity is higher for severe cases than for mild cases. One study reported a positive predictive value of 90% and negative predictive value was 76% for FPL in 206 sick cats. Positive FPL result indicated pancreatitis as a probable diagnosis, but the test cannot be used to rule out pancreatitis. In cytology allows for a close issue as a whole. Here we can see that is the cytology of the pancreatitis. There are multiple cohesive clusters, likely hyperplastic pancreatic exocrine cells characterized by increased cytoplasmic basophilia here. And background contains blood, erythrocytes here, cells here, neutrophils. Increased numbers of new neutrophils were observed with macrophages. In both acute and chronic pancreatitis, the absence of inflammatory cells should not preclude a clinical diagnosis of pancreatitis. Because inflammatory infiltration can be highly localized, especially with chronic diseases. Collection of pancreatic biopsy specimens in cats, surgical or laparoscopic biopsy procedures have been shown to have a low risk for complications. When evaluating tissue biopsy specimens from cats with suspected pancreatitis, the accuracy of histologic diagnosis can be limited by the multifocal distribution of lesions in cats with pancreatitis. Multiple biopsies are recommended, and pancreatitis should not be excluded based on negative biopsy result alone. Cross lesion. In acute pancreatitis, we can see pancreatic fat necrosis, focal peritonitis, hemorrhages, edema, congestion, fibrin that pass from the pancreatic surface through the omentum, mesentery, or the liver. Cross lesion of chronic pancreatitis often are more subtle, but in severe cases, the pancreas may be small with a firm gray multinodular appearance. Adhesions to the small intestine may be observed. There may be not obvious cross lesion observed with pancreatitis. In acute, here's the lesion as mentioned before. In a chronic, decreased size of pancreas and multinodular gray discoloration could be observed. And here's pictures of acute pancreatitis. We can see that is the duodenum and pancreas here. We can see that the pancreas is increased in size, edema, and hemorrhages here in the pancreas and the fat here. In the next image here, this is the pancreas here and the duodenum here, and arrows indicated the fat necrosis here. on chronic pancreatitis, we can see that the pancreas are mildly enlarged, and mildly we can see that there are multinodular appearance here. And in this image, we can see that the pancreas is here, which is decreased in size and with multinodular appearance, which indicated fibrosis chain. In pathology, histological classification and interpretation is important. Interpretation of pancreatic biopsy specimens should include the evaluation of inflammatory cell infiltrates, as well as their spatial distribution, include intralobular or interlobular, and presence of edema, necrosis, fibrosis, amyloid, cystic actin degeneration, or atrophy. Routine diagnostic pathology and may advance the understanding of pancreatitis in cats. The histopathology report should specify whether pancreatitis is acute, chronic, active, or chronic. Here we can see there are some lesions listed here, including inflammation, edema, fat necrosis, fibrosis, cystic degeneration, and these are the score from 0 to 3. Here we can assess the severity from mild to moderate or severe. In acute pancreatitis, one study divided acute pancreatitis in cats in two forms: acute necrotitis and we can see that it's acute pancreatitis in histopathology. There are some edema, hemorrhages, and inflammatory cell infiltration. Here we can see the pancreatic lobe is still observed in the section. In chronic pancreatitis, chronic pancreatitis in cats is characterized histologically by lymphocytic or lymphoplasmacytic inflammation, fibrosis, or atrophy. Can be extensive throughout the interlobular septum or extends into the lobules in severe cases. Extensive fibrosis also may be present, leading to localized stenosis and cyst formation with squamous metaplasia of the ductal epithelium. Pancreatic neoplasia also can be associated with chronic pancreatitis. Here we can see that this is the histopathology. We can see that the nodular appearance here, and there are abundant inflammatory cells, fibrous tissue infiltrate between these nodular structures. Okay, let's go to the management of acute pancreatitis. Whenever possible, the cause of acute pancreatitis should be removed or treated, but doing so may be difficult because most cases of pancreatitis are idiopathic. So management is predominantly supportive and symptomatic. Management of complications and diagnosis and treatment of comorbidities play an important part in successful management. Several diseases and risk factors have been associated with pancreatitis, most of which allow specific treatment. Some infectious agents that cause systemic diseases, which may include pancreatitis, such as toxoplasma, or other that rarely cause pancreatitis, such as these two pathogens, are amenable to treatment. However, because such cases are rare, currently there is no need to test for these organisms. Careful drug history should be taken, and those drugs implicated in causing pancreatitis in cats or other species should be avoided if possible. Fluid therapy. Intravenous crystalloid fluid is administered to correct dehydration and electrolyte imbalances. In addition to the adverse effects of hypovolemia, the pancreas also is susceptible to altered blood flow as a result of increased vascular permeability and microsome bifurcation. Establishing normal volemia using early IV fluid therapy may limit tissue damage by improving pancreatic perfusion and oxygen delivery. Dehydration, inaptitude, vomiting, and diarrhea can lead to hypoperfusion, resulting in metabolic acidosis and renal azotemia, which can be corrected by fluid therapy. Concurrent hypoglycemia, diabetic ketoacidosis, and kidney disease may further contribute to metabolic acidosis. Further study is needed to determine the ideal fluid choice for the treatment of pancreatitis in cats, but lactated, ringers, or similar solution often is the first choice. Antiemetics and gastrointestinal kinetics. Antiemetics are important to minimize fluid and electrolyte losses and to decrease the potential for regurgitation and secondary esophagitis. The most commonly used antiemetic in cats is maropitant citrate. It's a neurokinin 1 receptor such as visceral analgesia and anti-inflammatory activity. Ondansetron is a selective serotonin receptor antagonist, can be used as primary or addictive antiemetic. Because maropitant and ondansetron work by different mechanisms, metoclopramide has questionable central antiemetic effects in cats, but when used as a CRI, metoclopramide increased gastric emptying and decreased gastric atony. This is an effective PO kinase in cats and is a treatment of choice for delayed gastric emptying. Erythromycin also has been shown to have a gastric prokinetic effect in cats. This is the summary table of commonly used fluid therapy and antiemetics in cat pancreatitis. The dosage are listed in the right column for your reference here. The common usage fluid therapy and antiemetic therapy, including maropitant and ondansetron, here are listed here. In cat management, pain is difficult to evaluate in cats clinically, especially in the clinic. The cats are usually nervous, so it's hard to evaluate the pain. Opioids should be used as a primary analgesic for cats with acute pancreatitis. Buprenorphine is adequate for most patients, whereas methadone or fentanyl are good analgesic choices for cats with more severe pain. Oral buprenorphine or meropenem can be used for analgesia in outpatients. In addition, tramadol and gabapentin or a combination of these two drugs can be considered as PO analgesic options. In appetite stimulants, restoring food intake is an important factor in recovery in most patients. The most commonly prescribed appetite stimulants in cats are mirtazapine and apomorelli. Mirtazapine has been evaluated in aptant cats. Mirtazapine transdermal ointment can be used in cats and generally is well tolerated and efficacious. The safety and efficacy of apomorelli solution is an appetite stimulant and have been reported in healthy and sick cats. Studies have shown that the earlier a cat gets back to eating, the better the prognosis for good recovery. In patients with severe acute pancreatitis, early enteral nutrition is viewed as an active therapeutic intervention and minimize infected pancreatic necrosis. Or prevented from eating, patients will develop hepatitis, which will substantially increase mortality. Cats with mild to moderate acute pancreatitis often begin to eat with appropriate, supportive, and symptomatic care. In severe cases with complications, often will require a feeding tube for appropriate alimentation. Gastrointestinal motility. Intestinal villi may atrophy, compromised intestinal blood flow, altered barrier function, and the disruption of normal intestinal microbiota. Feeding tube can be used for hydration, administration of medicine, and for gastric decompression. Highly digestible diets, often labeled as gastrointestinal diets, are highly recommended. Placement of an enteral feeding tube is indicated for cats that fail to respond to appetite stimulants within 48 hours, or those have a history of more prolonged anorexia before presentation. Nasal-esophageal tubes or esophagostomy tubes are the most commonly placed tubes in cats with nasal-esophageal tubes. Feeding is limited to a liquid diet because the diameter of the tube is small. Placement of esophagostomy tubes requires general anesthesia and more technical expertise. I forgot to mention that the nasopharyngeal tubes means moderate sedation. The esophagostomy tube is an excellent option when long-term feeding is anticipated. And the esophagostomy tubes allows for feeding of canned diets. here we can see the picture at the left is the nasal-esophageal tube here. There's some tubes here. Tracheostomy tube here, located here. And we can see the diameter of the tube is large. Rats in which enteral feeding is not an option because of unmanageable vomiting, protein alimentation can be provided by PPN or TPN. It's partial parental nutrition and total parental nutrition. In advanced fluid therapy, fluid, electrolyte, and acid-base imbalances must be assessed and corrected as early as possible. In addition to correction of dehydration and maintenance fluid support with crystalloids, colloid therapy is beneficial when indicated to maintain and support colloid osmotic pressure and to prevent fluid imbalance and edema formation. In cats receiving aggressive fluid support, it is important to avoid volume overload by monitoring respiratory rate and effort, performing pulmonary auscultation, and measuring central venous pressure. And dopamine is a vasopressor that also makes pancreatic blood flow and decrease microvascular permeability. In persistently hypotensive cats, additional vasopressors should be considered, including norepinephrine, vasopressin, and epinephrine. Antibiotics. Antibiotics are not recommended for non-complicated cases of pancreatitis. Broad-spectrum antibiotics should be reserved for cats with acute pancreatitis in which pancreatic infection is suspected or confirmed. Infection has extended the common pancreatic or bile duct, or CBC findings are suggestive of sepsis. The localization and type of intrapancreatic bacteria suggest translocation of enterobacteria as a likely source. Corticosteroids. Corticosteroids are not used routinely for the treatment of acute pancreatitis in humans, dogs, or cats. Corticosteroids have broad anti-inflammatory effects, and research suggests that they play a key role in enhancing apoptosis and increasing production of pancreatitis-associated protein, which exerts a protective effect against pancreatic inflammation. No studies have evaluated the use of glucocorticoids in cats with acute pancreatitis, and thus there is insufficient evidence to recommend their routine use. Corticosteroids are beneficial in treatment of certain current disorders, chronic inflammatory enteropathy, steroid cholangitis, and should be considered if these complications are present in the patient. Management of respiratory complications. Tachypnea and labored breathing are common complications of severe pancreatitis in cats. It may be caused by pleural effusion or pulmonary edema secondary to acute lung injury or both. Acute respiratory distress syndrome, volume overload, congestive heart failure, aspiration pneumonia, pulmonary thromboembolism, pain, or some combination of these. Thoracic radiographs and Doppler echocardiography often permit rapid diagnosis to guide treatment. Thoracentesis with pleural fluid analysis is indicated in patients with pleural effusion. In cats with aspiration pneumonia, antibiotics and oxygen treatment are indicated. In pancreatic surgery, surgical management rarely is indicated in cats with acute pancreatitis, and clear indications to perform surgery have not been determined. In cats with severe acute pancreatitis and concomitant extrahepatic biliary obstruction or pancreatic abscess, surgical intervention may be beneficial. However, most clinicians are conservative when considering pancreatic surgery because most patients with severe pancreatitis are poor surgical candidates. Prognosis of acute pancreatitis. The mortality rate in cats with acute pancreatitis ranges from 9 to 41% based on 4 studies. Cats with mild to moderate acute pancreatitis generally have a good prognosis with appropriate management, whereas cats with severe acute pancreatitis, especially when complications or comorbidities are present, have a guarded to grave prognosis. Low plasma ionized calcium concentrations in cats with acute pancreatitis have been associated with poor outcome. Hypoglycemia and azotemia also are poor prognostic indicators. Management of chronic pancreatitis. Chronic pancreatitis in cats often occurs concurrently with other diseases, and the diagnosis and treatment of these conditions usually take priority. If chronic pancreatitis occurs as an isolated condition or appears to be a complicating factor that worsens the prognosis of complications, particularly diabetes mellitus, then targeted management is indicated. In analgesia, visceral pain is mediated by cytokines including substance P, neurokinin A, and the calcitonin gene peptide. And so traditional analgesics may not be effective in cats with chronic pancreatitis. Transmucosal buprenorphine may be used. For long-term treatment, gabapentin or tramadol may be better choices. Supplementation of pancreatic enzymes is no longer recommended unless subclinical exocrine pancreatic insufficiency is present. Nutritional support. Enteral nutritional support or dietary modification may be required for treatment of underlying or concurrent diseases, but rarely is required to manage it chronic pancreatitis as a primary condition. It is recommended that each cat's diet be assessed and altered if the diet is thought to have contributed to pancreatitis or comorbidity. In antiemetics, appetite stimulant is similar to the acute pancreatitis, including maroxetin, ondansetron, mirtazapine. In antimicrobials are not indicated unless required to treat concurrent conditions or infections complications. Other supportive treatment should be also considered. Cobalamin supplementation is indicated when hypocobalamin is documented. Prednisolone is a commonly used anti-inflammatory and immunosuppressive drug that is potentially antifibrotic and has minimal adverse effects in cats when used at low doses. The adverse effect of most concern is enhanced peripheral insulin resistance and the risk of diabetes mellitus. Some clinicians might think that prednisolone should only be used in cats that are not hyperglycemic and only at anti-inflammatory. Other clinicians might think that immunosuppressive dosages of prednisolone with close monitoring could have a beneficial effect. Other immunosuppressive drugs including cyclosporine with close monitoring and
Recording stopped.
also may be beneficial. In monitoring, if serum FPLI is increased at the time of diagnosis, it can be used to monitor response along with clinical variables. But the sensitivity of serum FPLI is lower in cats with mild disease than in those with severe disease. And like any other diagnostic test, this laboratory test should not be used in isolation to assess clinical remission. And these two tables are commonly used. Analgesics and sedatives are listed here for your reference, including analgesia, sedation here. You can find the dosage at in the table. In this table for your reference. In conclusion, accurate diagnosis of pancreatitis in cats requires the integration of history and the clinical findings, diagnostic imaging, laboratory data, and potentially cytology or histopathology. Depending on the clinical findings in an individual patient, additional diagnostic tests to rule out the differential diagnosis may be needed. Management of acute pancreatitis involves treatment of potential causes, fluid therapy, analgesics, antiemetics, nutritional support, and other symptomatic and supportive care as required. Management of chronic pancreatitis involves the treatment of potential causes, diagnosis and management of concurrent conditions, analgesics, antiemetics, and potentially an anti-inflammatory and immunosuppressive treatment. Okay, thank you for attending this webinar. If you have any questions, you can leave the message in the chat box And please find us on Facebook or LinkedIn. Thank you for attending this webinar.
邱医师可以听到我的声音吗？
可以。
您现在应该可以开视讯，我们已经有重新设定。This is a very knowledgeable lecture. So I hope all of you enjoy this webinar. And just if you have any question, please post your question. So, and I have one. So from your point, from your view, is pancreatitis or chronic pancreatitis is harder to.
Yes. In severe cases, hospitalization is indicated. The clinicians may need fluid therapy or insert the nasal esophageal tubes or esophagostomy tube maintain the nutrition. Once the nutrition recovered, then patients will get back.
Also, another question is there any breed preference for this disease, for pancreatitis?
Pardon, Dr. Lo, what breed?
Any breed-related prevalence?
Prevalence. In my experience, there's no breed prevalence in cat pancreatitis. Yeah.
Okay, there's one question from Dr. Joyce.
I see the questions and I repeat the questions. What are some, and here, there's a question here. What are some examples of drugs that can cause pancreatitis in animals? Oh, that is a very broad question. There are many drugs, including antibiotics or sedatives. In my experience, there's no test to determine what drugs is going to cause pancreatitis. So usually if you think this drug is causing the pancreatitis, you should stop using this drug immediately. Then measuring and then monitor the patient. Okay, is there any other question? And there's a question, can the disease be carcinogenic? Can the disease be carcinogenic? Oh, okay. In chronic pancreatitis, there might be a chance that the pancreas may develop into tumor, whether or malignant. So you have to imaging examination routinely.
Okay. Any other question? And if there's no any other question, then that's all for today's webinar. I'll thank Dr. Cho again for the wonderful presentation. Thank you, and thank you everyone for participating in this webinar.
Thank you, Dr. Low and everyone. Have a good night.
Yeah, and good night to everyone. Hope to see you again next time. Okay, bye.
Thank you, bye.
nói. Ủa phát đi con. Tắt cái